And from St. Louis, Missouri, and the home of the Missouri Institute of Mental Health, good afternoon and welcome. Thank you for joining us this afternoon. My name is Tom Pansella with the Missouri Institute of Mental Health. Thank you very much for taking the time to join us. I'm going to introduce our speakers to you in just a moment. I see a lot of new faces in the crowd today, so I wanted to give you a little feel for the real estate on the screen that you're looking at while you're watching today's program. Just immediately to the right of the video window, there's a little chat box right there. At any time during the presentation, if you have any questions or comments for us, for our speakers, please go ahead and type those in at that point. At the end of both of the presentations, we're going to have a little back and forth, a lot of time for discussion, but we'd like you to submit those at any time they come into your head or into your heart today. Below that, you're going to see, below the video window, there's an open caption. So if you'd like to follow along with the transcriptionist, you can follow along just below the video window. And below that, there's a couple of other links. You'll see a link to the slides eventually there. You will also see a link to a couple of websites. One website is for Lori Suthar's book, Joshua's Missing Piece. The other one is a link to the Midwest Pandas Conference, the Midwest Pans Conference, which Lori has helped organize and which Dr. Pollard will be speaking at. And that's going to be taking place August 7th and 8th in St. Louis at the Chesterfield Doubletree by Hilton Hotel. The link to the website's there, and all the information related to that conference is there as well. So we're going to introduce our speakers to you right now. First of all, we have Dr. Alec Pollard, and he's a returning victim in our shop here. We've had Dr. Pollard with us a number of times over the years. We really like working with him. He is the founder and director of the Center for OCD and Anxiety-Related Disorders at the St. Louis Behavioral Medicine Institute, and he is Professor Emeritus of Family and Community Medicine at St. Louis University School of Medicine. He's a licensed psychologist who works with a range of obsessive-compulsive and anxiety-related disorders with a special interest in patients ambivalent about or resistant to treatment. He's on the Scientific and Clinical Advisory Board of the International OCD Foundation, and he chairs the organization's national training initiative, the Behavior Therapy Training Institute. Dr. Pollard also serves on the Scientific Advisory Committee of the Canadian Institute for Obsessive-Compulsive Disorders and the Obsessive-Compulsive Cognitions Working Group Research Collaborative. He's also the former chair of the Clinical Advisory Board of the Anxiety and Depression Association of America, serves as a reviewer for a number of professional journals and conference program committees, and has authored over 90 publications, including 2 books. We could go on about his bio. We're going to give him a chance to speak this afternoon. Lori Suthar is a mom. She's also an occupational therapist for 20-plus years. She worked with children for a long time. She had 3 children of her own, decided to start working with adults. And I think that this is a presentation that's very, very near and dear to her heart. She is the author of Joshua's Missing Piece, which is her own true story. She's going to be telling that story in brief format today. But as I said, there is a link to the book on the program website today. So with that, I will introduce and turn the program over to Dr. Pollard. Good to see you again.
Thank you. Appreciate it, Tom. This is a very fascinating and exciting topic. There's a lot happening in this field. And as you'll find out, we have much to learn, but there are a few things that we can share with you today that we do know about this topic. My title is Beyond the Infection, Recovery from Pediatric Acute Onset Neuropsychiatric Syndromes. And I gave it that title because getting at the infection and its relationship to the clinical symptoms that these kids experience is only part of the story. You'll hear this, I think, more vividly when Lori speaks. But there's a lot more to the recovery process than simply trying to identify and manage the infection. So a little background for those of you, because I realize that there's a mixed audience here. Some know a lot about this topic, and others may know very little. But a number of years ago, a physician by the name of Susan Suedo identified this temporal relationship between infections and the onset of OCD, tic disorders, and a variety of other psychological problems, behavioral problems that sometimes go along with the OCD and the tics. And wondered, is it possible that the infection is actually in some way related to the onset of these symptoms? And she did a number of studies, clinical observations, and developed this hypothesis known as Pandas. And Pandas, we're going to talk about what that stands for and how that concept has shifted over the years. but it has to do with psychiatric syndromes that are believed to be connected to strep infection. Now, I think she later lamented using the word pandas as her, because when people search for this, they, of course, are finding out a lot about bears before they ever get to find out about the infections and the OCD. So we're going to talk a little bit about the recovery process, too, not just the history of PANS, but also what some of the similarities are with non-PANS OCD, for example, and what a few differences might be. And that's really what we're going to focus on today. So first we're going to do a quick review of OCD, tics, and associated problems with these two syndromes. Then we're going to do a quick review of history and the definition of PANS and PANDAS and a little bit about the historical background. Then we'll get into treatment options, and we're not going to be able to go into depth in that. And there are many of the treatments that are way outside of my expertise that I wouldn't be able to go into depth about anyway. And then we're going to talk about some of the issues, some unique to PANS and some not unique to PANS, that kids, their siblings, and parents have to deal with in trying to figure out and eventually recover from this problem. And then ultimately some resources that will be available to you, both nationally and locally. So, so let's start with just a quick review of what is the nature of OCD, tics, and associated disorders. OCD is a very confusing syndrome because it has multiple symptoms, multiple types of OCD and subtypes. And on top of that, it's portrayed in the media sometimes in demeaning ways or trivial ways or silly ways and often inaccurate ways. So there's a lot of misunderstandings about what is OCD. We'll try to shore that up here in a second. So there's two main features of OCD. I know this comes as a shock to you: obsessions and compulsions. That's why you came to this talk today, to find out this detailed information. But we're going to talk a little bit more about what these two things are. So the obsessions are the things that bother the individual, that make them anxious or distressed or put them in a feeling of not rightness, and we'll explain what that means a little bit. And these obsessions involve some feared outcome, like, and especially in adults. We see in kids it's a little bit different, but in adults you often will have, if I touch that dirty chair, I'll then contract a disease and die. So there's a well-articulated fear. Again, when we go to the younger kids, you're going to find it's a different picture. But what triggers that fear is something called either an external or an internal trigger. And these triggers can be things in the outside world, like contaminated objects, tasks involving responsibility. So contaminated objects, as you might guess, is associated often with washing and cleaning. Task involving responsibility would be associated with people who check a lot, double check, triple check, quadruple check. Asymmetry is another trigger, and this is when things aren't right, they're not balanced, and I use asymmetry in the widest word, things that are not quite right. And again, we see this a lot in the kids. The internal triggers are thoughts, urges, or images that create anxiety. And they usually are around either sex, violence, or blasphemy. We see less of this in the young kids, but you see more as they begin to get closer to puberty and in adulthood. But you will see some bad thought, what's called bad thought OCD in some of the young kids. Now, when they get scared, when they get distressed by the trigger, they try to do something to make themselves feel better, what we call neutralize the obsession. And those are called compulsions. Now, these can be behaviors or they can be internal processes. So some compulsions are very self-evident, and these are the more famous ones: washing, checking, reassurance seeking. You see that a lot in kids, trying to get reassurance that something is all right. repeating things in a sort of stereotype way, straightening, aligning, correcting, or evening things. These are all part of a perfectionistic spectrum of trying to get things just right. So those are some of the behavioral compulsions. The mental compulsions are things that our kids and our adults with OCD do inside their head. These are just the same as behavioral compulsions. They are aimed to try to make themselves feel better, to neutralize the obsession. And those can be counting, thought or image replacement. So for example, replacing a bad thought with a good thought, praying, not praying for religious reasons, but praying compulsively over and over again. Mental checking, where you're reviewing something in your mind that you have done to make sure you did it right over and over again. Figuring it out, and this one is, I think, more common in the older kids and adults, where you spend countless hours trying to figure something out in your head that cannot be figured out. So these are some of the examples of compulsions. It's not a complete list, but it gives you a sense of some of the things that people with OCD experience. Now, in kids, there are a few things that are going to be different that aren't as classic. When kids talk about the obsessions, they're much more vague on the whole. Now, this is a generalization, but it's largely true. So they don't tend to say things articulate. They don't articulate their fears like adults. They don't say, if I touch that chair, I'm going to die. It's more likely to be gross or yucky or not right. It's not always this well-expressed fear. The general anxiety that they feel is often responded indirectly. They don't say, I'm anxious. They'll ask for a glass of water, or they'll say their tummy hurts. They'll complain about feelings, but they're not obviously going to articulate anxiety and fear the way older kids and adults can do that. The distress that they experience can be directly from the obsessions, but it also can be from frustrations that they feel either from the burden of having to do the compulsions or having their compulsions interrupted by unknowing family members or being triggered unknowingly by unknowing family members, and often expressed as, I can't stand it, make it stop. There is aggressive behavior in a certain portion of kids with OCD, but generally it's secondary to the OCD, meaning that when they get aggressive, whether it's throwing something on the floor, punching a wall, yelling, screaming, it's often because they've been triggered by the OCD or they've had their compulsions interrupted. Or they can't get it right. They keep trying and they get. So the aggressive behavior is often an expression of their frustration with the OCD and not a natural tendency of the child necessarily. So let's talk a little bit about tics. OCD and tics are cousins, but they're not the same disorder. There are some differences. A tic is a sudden, recurrent, non-rhythmic stereotype movement or vocalization. So it can be a physical movement or it could be vocal tics. There are two types, motor and vocal. So motor tics would be like eye blinks, head jerks, things like that. Vocal tics can be grunts or snorts, but they can also be actual words. And of course, in our the media likes to especially focus on the curse words that a small percentage of people with tic disorders engage in, because it's more entertaining. But it's not the mean type of expression of tics that you see compared to grunts, coughing, sniffing, much more common. So these two types, motor tics and vocal tics, can either be what we call simple or complex. Simple tics involve a much fewer number of neurons, as little as 3, and are very, very automatic. Complex tics tend to involve a larger portion of the brain. So for example, within vocals, a grunt might be a simple tic, but a word, to actually produce a word, would be considered a complex tic, especially if it's 2 or more words. A motor tic, an eye blink, would be considered a simple tic, but more complex movements would be considered a complex motor tic. Okay. So again, I don't want to belabor this. The most well-known tic disorder is Tourette's disorder. You have provisional tic disorder, which is when the tics have been around for less than a year. Persistent motor or vocal tics is when you have either motor or vocal tics for more than a year. And Tourette's is when you have both motor and vocal tics for more than a year. There are a bunch of other problems that can coincide with OCD and Tourette's. Here we have a graph that shows you one study at UCLA looking at what other types of problems did kids with OCD tend to have. And you see ADHD, for example, about 20% of the kids have ADHD. Tic disorders, about 10%. Now, if you go into a Tourette's clinic, a tic clinic, you'll see that there's much more of them that have OCD. And that's an artifact of the fact that people who have co-occurring tics and OCD disproportionately tend to go to, say, a neurologist to get their tics addressed before they would get the OCD. So the actual co-occurrence is closer to about 10%. And again, you can look over the chart and see, but amazingly, if you think about the purity of disorders, it's more common to have 2 or more than it is to 1. 73% of this sample had 2 or more, meaning 1 comorbid disorder plus their OCD. So comorbidity and accompanying problems are very common in regular, so to speak, OCD, and as you'll see, also in PANS. So let's move then to sort of the concept of Pandas and Pans. As I mentioned, Pandas was a term that Suthar put together to refer to the pediatric autoimmune neuropsychiatric disorders associated with strep. And the idea was that the infection triggers an autoimmune reaction. That it's not the infection itself, but it's the body's response to the infection that is believed to then interfere with the area of the brain, in particular the basal ganglia, that's responsible for motor behavior. And that this is sort of the basic idea that got her doing her research and upon which Pandas is associated. Now, in just 60 seconds, give you a very quick history summary. A lot has happened since then. One of the things is that other infections have been discovered to be associated, at least potentially, with this type of syndrome. So it's not just streptococcal infections. It could be Lyme disease or other kinds of infections. The other thing is that some patients don't have any infections that they can find at all, but they have this unique characteristic which has to do with the rapid, sudden onset. But they don't find an infection. For that reason, a new term was promoted to sort of capture this group of syndromes. And that's where we got PANS, Pediatric Acute Onset Neuropsychiatric Syndromes. So you notice that not even, there are some that have proposed leaving autoimmune in it, but acute onset, there's no reference in the title to autoimmune. And that's because we actually don't know. There could be several subtypes. There could be an autoimmune subtype. There could be a non-infection related subtype that has a variety of other triggers. So one of the things that it was attempted to do is to end some of the bickering about what the causes are by putting a more neutral label on this group of syndromes so that we could then, as a group, research and study it without as much bickering. So this new concept focuses on what is really the unique and universal feature, because there's not much unique about the presentation of PANS in the clinic, except its sudden and rapid onset. There are a few things that are more prevalent in PANS than non-PANS OCD, but for the most part, the main unique feature is this remarkable change Tuesday, Junior is okay. Wednesday, he's in the shower for 3 hours, or restraightening and moving things about, irritable, having all host of symptoms, and some of which I think we're going to hear testimony to here in a minute. So what are some of these symptoms of PANS? Well, as I mentioned before, dramatic childhood onset, very rapid, very dramatic change. And again, I shouldn't assume everybody knows this. The normal course for OCD is a gradual progression of symptoms over time. So it's unusual outside of PANS to have OCD just sort of start on Wednesday. What you see is your child starting to do some unusual behaviors, and it starts to grow and starts to expand in terms of frequency and the situations in which they do it, and it's a much more gradual process. That has psychological implications that make PANS a little bit different in how you respond to it and how the family responds to it. So here are some of the things that you see: behavioral regression, sort of acting in ways that the child hasn't been acting, phobias, sometimes around eating, but sometimes other kinds of fears and phobias, urinary symptoms, sensory issues, sensitivity to tactile stimulations, auditory, not being able to stand noises, or even visual things that are not right, not being able to stand them. The motor regression, meaning in most particularly remarkable in handwriting, or you'll see artwork where a child has been able to draw a fairly sophisticated picture, and after this will draw, their drawings are more primitive. So some pretty remarkable changes in a very short period of time. Additional characteristics: generally we're talking about a very young age set, less than 9 years old. ADHD is one of those common things, but you notice that also is not unusual in non-PANS OCD. These meltdowns and aggressions and these kinds of behaviors, very, very common. Not terribly different than non-PANS OCD, except I think the rapid occurrence of the disorder probably makes these things more likely because the child is not used to these things. Okay. So here are some of the, as we talked about, other infectious triggers that besides Streptococcus, Lyme's disease, Mycoplasma, and others. There's no conceptual reason why viruses couldn't equally be involved in certain cases. And the other question is, are there other things, not just infections, but other assaults to the brain, either environmental or biological, that could possibly trigger PANS? So let's talk a little bit about treatments, and it gets complex with PANS, more so than OCD, because you kind of have these two categories of treatment. But first, we'll just talk a bit about evaluation. Now, this is one of the challenges, is finding the right person or persons to do the evaluation. But you want a good medical exam, not just psychological, obviously, but a medical examination and a physician who's willing to work and look at the possibility of triggers. Now, hopefully, the parents have done their job. They've noticed, can report to the physician recent illnesses indicating a possible bacterial or other infections. Throat cultures are a very, very common way to try to assess for this, but it gets complicated. It's not as simple as you get a positive throat culture, that means you have PANS, and if you don't have one, it means you don't have PANS. And we don't have time to go into the complexities of it at this point. But you find somebody who really is experienced and knows the literature on PANS. Okay. Now, if you do get a positive, what are some of the possibilities? And again, I can only briefly touch on these. Antibiotic trials have been tried with mixed results. Some studies have better results than others. I think whether or not, it's very likely that whether or not antibiotics are helpful with PANS is going to depend on a number of factors that we don't fully understand yet, but one of which is probably how close you're getting to the onset of the infection. The farther away from the infection, you may have less success on average with antibiotics. But we have much to learn about developing an algorithm that would really tell us all of these things, and that's why we need more research. Some things a little more dramatic than antibiotics have been tried, intravenous immunoglobulin, and this is where antibodies are administered to the patient from other donors. This has had some positive effects, but again, there are some mixed results. Plasmapheresis is a little more dramatic process, but in which the blood is actually removed from the body, treated, and then replaced. And so there are, plasmapheresis has some evidence that it could be one of the more effective treatments, but it is more expensive and more intrusive and has some risks. So steroids, mixed results, but again, if you're thinking in terms of hypothesis, possibly steroids. So these are some of the things that are options right now and have had some success at least, but we need more controlled trials to not just to see whether these treatments are fully effective, but also to try to figure out for which kids, which treatments are the most effective. It's not just which one is the best, but also trying to get better at matching children with treatments. Now, there's non-immunologic treatments for OCD and tic disorders. They're not perfect, but they're largely effective for many kids. And there's no evidence at this point that PANS kids respond any better or worse to cognitive behavioral treatment, for example, than regular OCD. We've had many kids with PANS have a positive outcome with CBT. And if one of the issues that we still have to grapple with is long-term outcome in this field. Even if you get acute results, the question is, are they vulnerable to relapse? Now, we haven't done these studies yet, but we do know that in non-PANS OCD, patients who have cognitive behavioral treatment have a much lower relapse rate than patients who just take medication. Now, is this going to be true for PANS children? In other words, can we cut back on relapse rates in PANS with cognitive behavior therapy? My guess is yes, but we don't know that yet. We have much to learn. The medication for OCD is primarily the serotonergic medications, and most of us are reluctant to use that with young kids unless we have to. So if we're going with non-immunologic treatments in young kids, then we're more likely to go with cognitive behavior therapy first, see if we can get results with that, and then add the medicine if we're not having success with CBT alone. For the tics, neuroleptics and antihypertensives are the treatments that are used with tics. And OT is occupational therapy, and I didn't realize you were an OT. So also, in the issue of losing fine motor skills, occupational therapy is a resource that can help some kids regain some of that fine motor skill. So let's go to some of the issues, and I won't be able to do it justice, but I think Lori will. But first, let's talk about the child. Imagine that you're a 4-year-old child, and all of a sudden, one day you wake up and you have all of these terrors affecting you. Now, some of these kids do have subclinical pre-onset levels of OCD, some of them, and some seemingly have none. But even if they have a little bit of OCD before this happens, the dramatic increase is shocking, frightening, and can certainly make a child feel out of control. Now, all the other things, whatever PANS has that's unique, it also is going to have all the other problems that regular OCD has. I feel like I'm at a gas station. I'll have regular OCD. it's too long to say non-PANS OCD. So they have the distress, the interference with functioning, and one of the things that I think gets underestimated, because we're so, rightfully so concerned about the horrible suffering that these kids go through, but they also lose joy in life. And we don't talk about that as much. That the things that other kids look forward to and enjoy, you don't see as much of in these kids because it's ruined by OCD. How about the siblings? This is not easy for them too, and they get affected in many different ways. They're directly affected sometimes by the compulsions interfering with, why can't we go to dinner? Where's Johnny? Why are we waiting on Johnny? He's been in his room for an hour. Well, he's doing compulsions, and we can't get him out of his room. Or conflicts. They don't understand. They think they're faking it. They think they're just doing it to get attention. The other kids aren't as mature. They don't have the perspective. They get into fights with the kid that has the OCD. Then they feel neglected because Johnny gets all the attention. Or how come Johnny gets away with that? Because you don't let me get away with that. Just because he has OCD, why does he get to do that? So there's sometimes resentments or fears. What if I got it? And embarrassment and shame. Friends coming over are going to see my odd kid brother or kid sister doing their weird stuff, and it's going to embarrass me. There's a lot of stuff that siblings have to grapple with, and I'm sure I haven't even captured all of it here. Now parents, the list is even longer, believe it or not. I got 2 slides for the parents. How you like that? Okay. All right. And I'll bet you, Lori's going to tell me if I missed anything, because I'm sure I did. All right. So what about the indirect impact? Okay, so by that I mean it's not the effect of the child's behavior on you as a parent directly. It's your concerns about them, even if it doesn't interfere with your life. You're worried about them. You're wondering what's wrong with them. You're concerned about how the suffering, or if they're older, how are they going to manage in school? Is this going to put them behind in school? Are they going to be able to function? And the guilt, did I do something wrong? Is it my fault? Or even if you don't have that antiquated idea that it's your fault they have OCD, even if you're more modern, you've got to at times have guilt about, am I handling it right? Am I doing the right thing? I don't know how you can't. Then there's the direct impact. There's all the disruptions to family life that are caused by the child's compulsions. The dinner table, the morning routine, getting up, getting going, trying to get things going, all of those things. And then having to deal with the siblings' reactions to things on top of that. Sometimes there's even concerns about threat to safety. Will this child hit me? Will this child throw something? Or their safety. Will they get injured pounding the wall with their hand or banging their head? Then there's all the school and academic issues that you have to deal with. Having to deal with accommodations at school because your child can't keep up, or because they have certain weird behaviors that the other kids don't understand, or on and on and on. On top of all those things, now you have special challenges with PANS. So all those things I described are true of all OCD, but on top of that, with PANS, you have this special emergent nature of PANS all of a sudden. So you don't have time to gradually adapt and try to think things out and figure out things as your child seems to be developing this unusual behavior. You all of a sudden are now having to deal with this very crisis-like situation and having to adapt rapidly and make quick decisions. It's not something you sit back and idly try to think about, because you see how much your child is suffering. And then there's the treatment quest. What do I do? Where do I go? Now remember, most parents, when they see it, they don't know about PANS or PANDAS. The first thing you got to do is try to figure out what's going on. And they don't know about what we know. So they got to find out what's going on, and they may not even know about OCD, or have even thought that their child has that, or tic disorders. So the challenge of finding good evidence-based treatment for OCD is still today a challenge, better than it used to be. And I thank the International OCD Foundation for that, because they have really been right at the forefront of trying to get more therapists and more psychiatrists trained. However, it's still a challenge. But on top of that, with PANS, now you've got to navigate the medical system and try to find the right treatment for your child. Will it be medical? Will it be cognitive behavior therapy? Which will it be? And you're going to have to navigate all the differences of opinion in the field, of which there are many. Now, do I treat the PANS? Do I treat the OCD? Do I treat both? What do we do? Do I go medical? Do I go psychological? Which is it? What combination of treatments is the right treatment? And boy, if you have any sense of trying to be the right parent, and you don't have some guilt or doubt about this, you're not human. It's a challenge. And then evaluating and continually reevaluating the risks and benefits of the different options. Okay, now I've probably depressed you all with all of this stressful talk, but Lori's going to calm us down. But first, I'm going to just tell you a few resources that are here. These are some organizations that are national, in which you can get information. And of course, the Pandas Network is involved in this whole meeting and everything. And the Midwest group is really the group that's got this meeting going. The Pandas Physician Network is very obviously a website that promotes information for physicians and communication between them. The OCD and Parenting Online Support Group really deals with OCD issues in general, as does the OCD Foundation, but they have some great resources for Pandas, specifically on the OCD Foundation. Additional sources, a great series was just published this year in the Journal of Child and Adolescent Psychopharmacology. It's a great summary of the field if you wanted to just go one place and read all those articles in the February 2015 journal. And or if you're not quite, excuse the reference, not so compulsive, you want the Cliff Notes, go to FAQs about Pandas on National Institute of Mental Health. Local, regional, now I say this because this meeting is going to be here in St. Louis, so I wanted to just emphasize there are some resources here. The St. Louis OCD Support Group doesn't do a lot or talk a lot about Pandas, but there are other parents there so that parents can talk about their kids with OCD and get some support. Obsessive Compulsive Anonymous is mostly for adults, so it's not so relevant. And of course, the Midwest Pandas Pans Parent Association, which Lori is part of, and that's a very, very important resource for folks in this area. In terms of treatment, our Center for OCD and Anxiety Disorders would be one option. We're going to be better at the OCD end. We do deal with PANS, but we're gonna I think what we do as well as anyone is the OCD aspect of PANS and also the tic disorders. Child and Adolescent Psychiatry in Washington University, which I know they are one of the co-sponsors of the meeting that's coming up, and Tracy Fritz, who's in family medicine here in St. Louis, does some work with PANS, and Michael Cooperstock in Columbia, Missouri, are people who have been identified as people who work with PANS. So in conclusion, we need a lot more research, and these are just some of the questions we need to answer. What factors are necessary for the development of PANS? And notice I said factors, not factor. Actually, very few things end up being caused by a single thing. And even Dr. Suedo, who couldn't be more of a proponent for the concept of PANS, does not say, and it's never been proposed, that infections cause OCD. The person has to have some other factors that make them vulnerable to the development of OCD. Otherwise, everybody who got an infection would have OCD. So what are those factors? What is the difference between a child who gets a strep infection and develops OCD and doesn't? Is this one syndrome or a collection of syndromes that have different causes? We don't know. And which treatments will be effective, and importantly, for which individuals? And really ambitious here is, could we get to the point where we could predict and maybe prevent PANS? That would be terrific. In the meantime, we have standard OCD tic disorder treatments, and we have immunologic therapies that offer hope of a better life to many kids and their families. Now, I'd like to turn it over to, speaking of families, to Lori to talk about her own personal experience with this.
Thank you, Dr.
Oh, you
Pollard.
don't need this?
No. I'm Lori. I wrote the book, Joshua's Missing Piece. I am co-president of the Missouri Pandas Pans Parents Association here in Missouri. And our story started, my son, who is now 12, was about 5 years old. He did have probably some underlying OCD tendencies, but, nothing significant. He had a normal childhood, hit milestones on time, no problem. And I very specifically remember taking him to karate on a July day, and all of a sudden he started clicking in the back seat. I said, "What are you doing?" And he said, "I can't stop." And I said, "Well, you're going to have to stop. You're driving me crazy. Let's go." Got out of the car, went into karate, and it was a testing night. And within 30 minutes, he could not really move across the floor without touching his heels, clicking, eye rolling, just everything all at once. And because it was a test, of course, the instructor kind of shooed everybody out of the room, and he was real excited, so I didn't want to take him out. So I called my husband and said, we've got to get him some help. There's something bad wrong. I went back in, and I kept telling him, let's go, and, he didn't want to leave. So he finished, and we left, and it kind of actually calmed down. By the time we got home, we had other things going on, and then the next day it started back again. It was click, 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 and it would stop when he was asleep. I would know he was asleep because it would stop. So I called our pediatrician, and she said, "You need to go ahead and go see a psychiatrist." So we took him, and the psychiatrist spent a long time with him, and after about 30 minutes, he started the clicking. He was up during the visit. He was climbing on the bookshelves, really impulsive, kind of all over the place. So he said, let's give him something for attention deficit disorder. And at 6 years old, Joshua was 36 pounds. So I was against anything stimulant that would decrease his appetite. So we put him on a non-stimulant ADHD medicine. And then he also put him on anti-anxiety medicine, Zoloft, which was a lot for us because we just, we didn't believe in a lot of medications for our kids. So came home a couple days later. I noticed he had this rash on his stomach, and I said, "Oh, mom moment, you must be allergic to something." So I gave him some Zyrtec, and then 2 days later, the rash isn't gone. He said, "My throat's kind of scratchy," and I said, "Well, let's go to the doctor." I called the psychiatrist's office, and I said, "Is this from the psych medicines?" Because by this time we'd been on him for maybe 3-4 days, and he said, "No." He said, "That doesn't sound like that. Why don't you take him in to the pediatrician?" So I did, and they immediately looked at it and said, "Oh, that's a strep rash." So I said, "Oh, okay." So they gave some antibiotics, and I started him on him at home, and in about 3 days, all of his symptoms got better. He stopped ticking. He was calm. At that point, we were home. We were doing some schooling at home, and he could focus. It was all better, and I thought, fantastic, the psych medicines are working. So we went on. He went through his 10 days of antibiotics, and within about 4 weeks, he was crazy again. Crawling off the wall, just really, nuts. So I took him back to the psychiatrist, and we added another ADD medicine for him, and they upped his dose of Zoloft. And, the ADD medicine did sort of kind of turn him down a couple of notches, but there were still problems. And then he started not sleeping. And so now we're getting to September, October. We didn't put him in school. He would stay up all night long. He would fall asleep maybe from 4 to 6 in the afternoon. And, of course, my husband or I, we kept making these small adaptations. Well, we can't leave him up all by himself all night, so one of us will stay up all night. And so we would take turns. I have a meeting, so you stay up with him tomorrow. And so anyways, our family life really began to change, and we were making such small adaptations, we didn't realize how really out of control the situation was. So anyways, my parents said, "You all go take a break, let us have the kids." And so on the break, I happened to read a book about another boy Saving Sammy, who had something similar. It wasn't quite the same, but there were some similarities. So I mentioned it to my husband, so we decided we would take him back and test him for strep. He had no signs. He had no fever. He had no sore throat. He had no rash. He had nothing. So when I called our pediatrician, she was like, "I think I know, where you're going." I think she had heard of it. She said, I don't mind putting him on a round of antibiotics to try, but you really need to bring him in and let's make sure, before we give him this, that he doesn't have strep. And I thought, okay, I know he doesn't have a sore throat, but okay. So I took him in and his rapid test was positive. I think the statistic that I've heard is about 46% of the kids who have Pandas come up with a positive rapid strep. So it's not all of them, but thankfully we were in that percentage that was, and thankfully she had us come in because we knew at that point. So she gave him an antibiotic for the strep infection. And by this point in the game, we're having rages at night at about 6 o'clock. And so my husband would take care of our other 2 children. I didn't want them to witness all the excitement, so I would take him upstairs and we would just, where he was safe, but he could get angry and in a safe place. And he was very targeted against my daughter. The constant ticking, by this time we had eye rolls, we developed a leg twist, we had clicking, we had all sorts of things. And we actually numbered them, we counted them because of my history in ABA with children with autism. I kind of knew how to track stuff, so we wouldn't be imagining things if it got better. So after about 3 days on the Augmentin, I had a different child. Very nice, would play with my daughter. The tics were all but gone. We would have 5 in a day as opposed to almost nonstop. He was eating, his little teeny tiny mini bites went away and he was eating meals. And I thought, wow, this is incredible. So my husband is a physician and he said, let me call around and see if I can get some help. And we were really not able to find any resources in St. Louis at that time, because this is, now 2000 and it's 2009, 2010. So he made some phone calls to some people in California and Chicago, and the physician said because of the rapid onset and the strep, you're looking at Pandas. He really felt confident of that. So long story short, we scheduled him for an IVIG, like Dr. Pollard had talked about, and the tics immediately went away. They were gone. They had been gone from the Augmentin, but anything that was left were immediately wiped out. He had an increase in rages for a couple of weeks after, and then everything just began dropping off. Again, everything that had improved with the antibiotics improved to a greater degree after the IVIG. He started eating more, he played, his handwriting was great, and at this point we were hoping to put him into school. He had spent his first grade year at home being homeschooled because we could not leave the house. So second grade, he had the IVIG the beginning of August, and by the beginning of September, we put him in school and no one knew his history if we didn't tell him. There was no evidence of anything. 3 months into school, the tics came back. He had a couple of viruses, and the tics came back. We immediately put him back in for another IVIG, and again, immediately the tics went away. And it's been 5 years now, and we have not seen them return except for he had one positive strep infection, I guess last year or the year before. And like we thought we were good for 2 weeks. He took the antibiotics, everything was good, and then all of a sudden he just developed these major head jerking movements where he just really hurt the muscles in the back of his neck. And so we have a physician now in St. Louis who's wonderful, and she put him on an antibiotic, and within 3 or 4 days, the tics stopped. And we had to keep him on that antibiotic for about a month. But, then they went away, and we really don't struggle with that. He struggles with a few compulsions these days that have not really gone away. Other than that, if you met him, you wouldn't math. He react even if strep is going around. He will react even if he does not have an active infection. I know 48 hours before they have a strep outbreak at school, I can call and say, "Do you have someone who's got strep?" And they'll say, "Not yet." And I'll say, "Well, he's having a hard time sleeping, and we're noticing increased anxiety." And typically within 48 hours, they have people reporting that they have strep. So we have to be careful of him from an immune standpoint, but other than that, he does very well. So that's our story.
While we're Together, we'd like to encourage everybody to submit questions. We got a couple people in the room with us as well. If you have any questions at any point, raise your hand, grab the microphone in the room. If you have questions online, please submit them using the chat window next to the video screen. We did have a question come in fairly early on about connecting people with resources. We had some actually nice chat going on with the audience among themselves, and they were connecting each other with resources, which was kind of fun to watch. But is there a reason to believe that that frequent bedwetting would be associated or affiliated with PANS?
Yes.
Yes.
If you have a child who is toilet trained and has been toilet trained for a while and starts wetting the bed, you either have a UTI going on, urinary tract infection, or it is something to look at if it falls in conjunction with some of these other symptoms. One of the conference talked about that as a big, I think 85% of the kids have that.
Yeah, it was in one of my slides, but I didn't emphasize it. It was just like a little side note. But yeah, that's very common.
Does getting the tonsils taken out help?
Well, we have had ours taken out. It does help if you have a child who has frequent recurrent strep infections and has this problem. I will say, for our case, just like Dr. Pollard was saying, there are some other things that go on that you need to look at immune function-wise. Taking the tonsils out very rarely just gets rid of the whole problem. It has happened, but it's not on the recommendation list for, if you have a Pandas diagnosis, to immediately remove the tonsils.
Yeah, and there's other ways you can get the infection, so
Yeah.
It wouldn't be a panacea for sure.
We had both strep A and strep B high levels in his gut while on antibiotics. So you can have a gut strep infection and not even know it, no symptoms of that.
Well, there's a great opportunity here for you to do a commercial for the conference. Who can attend the conference in August in St. Louis?
We have CMEs for physicians for day one. We have CEUs, clock hours, and contact hours for mental health professionals for day one and day two. And for nurses, I believe 7.25 hours for nurses as well. Anyone can attend the conference. Parents, physicians, interested people can attend the conference. It's just about signing up. Day one is only for, as far as questions are concerned, we're really trying to reserve day one for the physicians and the CME providers to be able to ask the questions. And then day two will be more parent involved. We'll still have Dr. Sweeto, Dr. Cunningham. Dr. Sweeto has the NIH study results that she's going to talk about some of those, which is really exciting. Mm-hmm. And she will be there on day two on a panel also. So if parents want to ask questions, she will be presenting on a panel. We also have a teen panel of kids who have gone through this, who will be also answering questions. So parents can ask questions of, there is a success rate. These kids do get better, and they can get better with correct treatment, but their perspective will also be there as well.
I'd just add that I'm looking forward to hearing the latest results too, because this has been a long time coming, and some of the prior studies have had weaknesses, and so that's caused some of the disagreement. So this study won't resolve everything, but it will help clarify a few things. So it's an exciting results to hear about.
Yeah.
So one of the questions that I had, and I was a little confused early on, but from your story, everything you're describing is your child's having these tics specifically around an infection.
Yes.
So is that the way this works in general, is that it's with the infection, or is there, outside of that, 4-week window, a lingering effect of the OCD or other disorders outside of any relationship to an infection?
I think that absolutely it can linger, and I think this is where therapy comes in huge. Because when a child is in an active and has an active infection and is in an active flare with the OCD, there's really nothing you can do until you clean up that infection. After the infection is gone, a lot of times it's gone on so long it's become behavior, and they have to unlearn it. And so I think that's where therapy is very important, because that's what has to happen. They have to go back through the process of learning, I don't have to do that. That was part of this illness.
Yeah, I agree. And you had a great outcome, and not everybody's as fortunate as you are. So And it depends on so many factors, how many times you're assaulted with infection, what your genetic predisposition is, how strong your genetics are to develop OCD can make a big difference. So there's many factors, how fast you get treatment. And many things that we're going to learn someday, some of which we might learn at the conference.
Yes.
Okay, how did I do okay giving a plug
that was
there?
awesome.
Okay,
Yes.
all right. But if you took 5 parents up here and each of them told their story, you'd hear 5 different scenarios, and that's why we just have so much to learn about it. But I'm delighted how you turned out, how great
Yeah.
that turned out. That's wonderful.
How do you test for the gut strep infection that you referred to?
We actually did a stool test. And turned it in, and they ran the test. They found strep A, strep B, and another opportunistic infection, which, when your body makes abnormal antibodies to strep, that's a problem, to have high levels of strep in your gut. So.
That also speaks to, I think, the importance, at least now, because this isn't common practice, doing this level of investigation,
Yes.
right? So this speaks to trying to get to somebody who would know even to do that. And at least until it's more common among pediatricians to sort of have a regimen of investigations that they do systematically. Yeah.
So I had one other question. You mentioned early on that this seems to affect the basal ganglia particularly. So is there evidence, what type of evidence is out there showing that that's the target area for this? Or is it just based on the motor
The
response?
basal ganglia is hard to look at an MRI, but they were able to do it. At the Northeastern Conference, I actually went to that, and they had some actual MRI. It was proven that there is swelling of that area in the MRIs. I know there's a physician in Michigan who is doing some PET scans with a lot of these kids. So there is some MRI evidence of swelling, the caudate nucleus. But it's not something I think you can just walk into a hospital and ask for, Yeah.
No, we do. That's a fair question, because I think that hasn't been absolutely identified as definitively as, because we don't have the research to really demonstrate it. Like you said, that one study certainly suggests it, and it is a difficult. It's not easy to do in imaging kinds of studies. So I think that, again, that's another one of those things that we really have. Maybe there's other areas of the brain that are affected. Maybe it's not just the basal ganglia. And so, again, more research so we can understand it. Yeah. That, by the way, I think is part of the reason that we went beyond Pandas to Pans. Because if you tie a disorder to a particular specific theory, you limit the research, because I think it was a great advance to go to PANS, because now we can start to look beyond the basal ganglia, look beyond strep, look at all sorts of possibilities without getting into unnecessary arguments. You don't want people arguing about whether the syndrome exists, getting into the theory rather than seeing the symptoms as they present and really trying to figure out what's going on. So.
And somebody throw a question in here about whether or not any elements of the conference are going to be recorded and made available.
We are currently talking with Washington University about that right now. We have a documentary guy that's coming who has agreed to film the entire conference for us. So we are hoping that will be okay with Washington University. We know the second day will for sure, that's just our organization's day. So the second day will for sure be taped, and we are hoping that we will be allowed to do that through Washington University for the first day as well.
All right, I think we've reached the end of today's program. Folks, there's the link's still active on the bottom of the page. They'll also be sent to you in email. One thing I didn't plug at the beginning is if anybody is interested in continuing education for this program, those are available as well. That link is active on the screen. That'll be in a follow-up email. We'll link to the slides in the email as well. And we'll also keep active the link to the conference for you and send that to you. So if you haven't already sent us an email address, you can kick us a note at feedback@mimhtraining.com and make sure we get your email address, and so that we can send you this information following today's program. We thank you for taking the time to join us. Alec, Lori, thank you so much for your time and your expertise today. It was a fast hour.
Thank
you
you.
very much.